Hi, my name is Dr. Travis Williams, and I'm so excited today to talk to you about cellular therapeutics and some of the encouraging frontiers of cancer treatments that we'll be talking about at St. Luke's Cancer Institute today. Cellular therapeutics has started out many, many years ago in the 1970s, and one of the main things about cellular therapy that was a problem is the cancer has evaded the immune system. And so we're using a donor's immune system to try to kill the cancer, and that's called an allogeneic stem cell transplant. The problem with an allogeneic stem cell transplant is those donor cells also would try to attack other parts of the normal recipient's body and cause severe disease conditions called graft versus host disease. Later in the 1970s, we found that we could collect a person's own stem cells, give them high-dose chemotherapy, and then give them a stem cell rescue. That's called an autologous stem cell transplant. A couple of the more exciting things that has happened in the last 5 years are called Chimeric Antigen Receptor T cell therapy, or CAR T therapy. Those are where you're collecting a person's own T cells, as you're sending in for manufacturing, and then they come back and are given to the patient to attack the cancer directly. So you're using your own immune system that the cancer cells have been evading, and now we've retrained it or reprogrammed it to attack the cancer cells themselves. Some of the things that are not yet developed but are in the works are using an off-the-shelf product where there is no manufacturing or processing. So no delay, a patient comes in, they have a cancer that needs treated. I can use off-the-shelf CAR T cells and treat the patient directly. And so that's very exciting because some of the big delays are the manufacturing and finding the right patient for the right product. So CAR T therapy, or again, chimeric antigen receptor T cell therapy, is you're taking someone's own blood via an apheresis process. You're taking it out of the patient, spinning it down to collect only the T cells, and that's part of the immune system that we want. Those T cells are sent to a manufacturing location in the United States. They're manufactured and they're actually infected with this very specific virus that encodes those T cells and makes them ready to attack cancer cells. We can encode different things into the T cells to attack different types of cancer. And currently, the products that we use it against are for multiple myeloma cells and lymphoma cells, as well as a couple different types of leukemia. Once the cells are ready from the manufacturer, they're shipped back to our center and they're infused directly into the patient after they receive some chemotherapy to get rid of some of the innate immune system cells that are there. Once those activated T cells are ready to go, they will be infused into the person and they'll automatically go out and find any cancer cells that express that specific protein that they're targeted and trained to kill, and those cancer cells will die off. This is an amazing therapy because you don't have to worry about these new T cells or these new immune system cells attacking yourself. They're only after the very targeted cancer cells that have this very one specific mutation. This therapy was initially designed early in the 1990s as a first treatment for HIV. And over time, we found we couldn't kind of figure that process out. But in the late 2000s, 2017, after multiple iterations, it was first approved for treatment of acute lymphoblastic leukemia in 2017. Also in 2017, a different product was approved for non-Hodgkin's lymphoma, specifically diffuse large B-cell lymphoma. And now in 2022, it has achieved approval for 5 different types of lymphoma, 1 type of acute lymphoblastic leukemia, and multiple myeloma, all hematologic malignancies where the previous treatments to this have all had very dismal outcomes. So the current 5 products that are approved, they have very complex names. The first one is called ide-cel. We take the first 3 letters of the scientific first word and the last 3 letters of the scientific last word, and that's how we get the abbreviation. So ide-cel is a CAR T product against multiple myeloma that was approved in 2021. The second one is liso-cel, is approved this last year in 2021 for adults who have acute lymphoblastic leukemia, also have relapsed diffuse large B-cell lymphoma. Chimera and Yescarta are both on the list So Tisa-cel and Axi-cel, both approved for acute lymphoblastic leukemia, diffuse large B-cell lymphoma, relapsed non-Hodgkin's lymphoma, as well as marginal zone lymphoma. And then Tecartus is approved for patients who have had mantle cell lymphoma that has relapsed after 2 lines of therapy. So these are very exciting to have multiple products that are available to us, because the manufacturing process that happens can take several weeks to get the product back from the manufacturer, and that allows us to have some options for patients if there's not a manufacturing spot with one company, that we can go with a different company. So currently, those are the indications that they're approved of, but if you look at the current clinical trials that are enrolling patients across the country and across the world, there are over 1,800 clinical trials that are registered and are actively enrolling patients for all sorts of different cancers, as well as other conditions, including HIV, and then cancers that are very common, such as brain tumors, liver cancers, pancreatic cancer, esophageal cancer, and lung cancers. One of the major problems with CAR T therapy is you have to have a target on a cancer cell that isn't present on normal cells. And so that's where it's been hard to find the right targets in many of these cancers that we have, but we're finding more and more options to target different proteins as we understand more and more of cancer biology. The other thing that's being done, instead of just using T cells, we can use other parts of the immune system, like natural killer cells or NK cells. What we found with that product in early phase 1 clinical trials is there's a lot less side effects, and you'll have equal efficacy. And I think that, again, moving these treatments sooner and sooner in the therapy of a patient will offer both longer-term progression-free survival, so they'll live longer with their disease, but also offer more patients a potential at a cure of their disease. I always like to think of this as we are unlocking the immune system and unleashing that new immune system on cancer cells and allowing those cancer cells to die in a normal programmed death way. It also provides an ongoing living maintenance therapy. So one treatment, and hopefully as those CAR T cells or CAR NK cells are hanging around, they will continue to provide treatment as long as that cancer cell if it does develop, it expresses the marker that the CAR T cells are targeting. We found that by adding CAR T cells that have multiple targets, we can also keep cancer cells away longer, because now you're attacking not only 1, but 2 or 3 targets. The immune system, our own immune systems are amazing that we can control, in a majority of situations, can control cancer on its own. It's just sometimes when that immune system needs help that we need something like this therapy. So all of these therapies have been approved in the last 5 years. This is an amazing technological pace, and the field of cellular therapy, specifically CAR T therapy, is changing at a dramatically quick pace. There's currently, if you compare these therapies to the standard therapies that would be eligible for a patient, 1 out of 5 patients might be alive in 6 months versus 4 out of 5 are alive, and in a lot of these situations are alive with no evidence of their disease. We're finding ways to make these cell therapies better and better, and allowing more and more patients the opportunity to receive this treatment. With other therapies like an autologous stem cell transplant and an allogeneic stem cell transplant, age and medical comorbidities definitely limit the amount of people that can receive these therapies. But with CAR T therapies, where you're using your own immune system and unlocking that immune system, unleashing it on the cancer cells, we're able to give this therapy to more and more people. Currently, these treatments are only offered to universities and academic centers across the country. You have to have what's called a FACT accreditation, which means that you go through all the necessary steps of being a transplant eligible facility where you're doing both allogeneic and autologous stem cells. At St. Luke's Cancer Institute, we are one of about 10 institutions across the country that is outside of an academic institution performing both autologous and allogeneic stem cell transplants, and hope to be early adapters in CAR T therapy as well outside of academic institutions. Why are we doing this? Why is this so important? Well, presently, if somebody needs this therapy, and truly has the potential for not only curative therapy, but life-prolonging therapy, the current locations where they have to go are Seattle, Salt Lake, or University of Oregon in Portland. And so that's a long ways away from family. They typically have to spend between 30 and 45 days at that facility with a caregiver that's with them 24 hours a day, 7 days a week. So there are lots of obstacles for our patients to get these therapies. It's very costly to live outside their home and their support network for those 30 to 45 days. There's lots of people have lived in Idaho, grown up in Idaho, and never want to spend any time out of Idaho. And so they don't want to travel to these other places. But we have great relationships and they have lots of support to help our patients at the present. And we want to be able to do that same thing for fellow Idahoans. Some other things that are coming down the pipeline, and people are able to do more and more therapies that are off-the-shelf therapy. As this technology continues to grow and develop, it'll be safer and safer for more and more patients. Patients often say when we talk about these therapies, it's too long to drive, it's too expensive to fly, and I can't hire a caregiver to take care of me and my significant other at this time. So our vision here at St. Luke's Cancer Institute is to continue to bring these innovative and exciting therapies to the wonderful people of Idaho. I was born and raised in Idaho. I received medical training outside of Idaho, but knew I wanted to be back here with my fellow Idahoans. We have to be able to train and recruit experts in this field, not only physicians, but advanced practice providers, the clinical and research staff, as well as administrative staff to make this program successful. We have to do several upgrades to our laboratory facilities, as well as our clinic facilities and electronic medical record updates. So our goal is to continue to, as has been, to provide continued treatment options for patients starting in March and April of 2022, which is very close, and we're getting very excited about this. What does this take? Well, it requires a wonderful administration that's been very dedicated and motivated to moving forward this plan. Well-trained and nimble clinical teams. Again, clinical data is changing on a weekly or every 2-week basis. So we are spending lots of time researching and learning how to do this well. Collaboration not only with our clinical staff, but with the pathologic and laboratory staff. We have to have patients who trust us and are willing to take and be one of the first to receive this therapy in the state of Idaho. We need the physical facilities, we need advertisement, we need community support. We have lots of good partners at other institutions, both locally in the Treasure Valley, as well as across the region that we serve, that are supporting us and referring patients currently. It's most important that we have philanthropic donations and support. And without those donations and support, we wouldn't be where we are, and we wouldn't have the possibility of moving forward with this as a potential for patients in the state of Idaho. We will continue to work with our industry colleagues and ongoing research and development, and we'll continue to participate in research moving forward, as well as working with other institutions across the country in collaboration to help move the needle and move better care for the citizens of Idaho and the United States. So again, I'm so excited about this treatment option. I'm grateful that I was able to share my passion for this treatment with you, and thank you very much.